Hello, my name is Alan Williams and today I want to talk to you about non-invasive ventilation. Often, patients requiring non-invasive ventilation are the most difficult to manage in a hospital, which is why emergency, medical and critical care physicians and nurses need a good understanding to deliver optimum care. Let's look at a case. A 78-year-old gentleman presents with shortness of breath. His regular inhalers aren't helping and he's coughing up some purulent sputum. Despite maximal medical therapy, his blood gas shows respiratory acidosis and relative hypoxia. He would be a candidate for non-invasive ventilation. The definition of NIV is the provision of ventilatory support to the patient's upper airway using a mask or similar device. It can either be continuous positive airway pressure, CPAP, or non-invasive positive pressure ventilation. Traditionally, negative pressure systems or iron lungs were used. These were superseded in the 1980s by positive pressure systems, initially in the treatment of nocturnal hypoventilation and then in acute hypercapnic and hypoxic respiratory failure. We use non-invasive ventilation to provide early ventilatory support with the preservation of normal airway defences. It avoids endotracheal intubation and the associated complications and therefore less pressure on tertiary intensive care beds. It can be used intermittently and has been shown to reduce the length of stay and provide a mortality benefit. The disadvantages include that the airway is not totally protected and you are unable to suction the bronchial tree. More commonly seen on the ward is the claustrophobia associated with a tight-fitting facial mask and pressure sores for long-term non-invasive ventilation use. Considerable medical and nursing expertise is required outside of the ICU setting. On the left, we see how CPAP provides continuous positive pressure, usually between 5 to 12 centimetres of water, and aids oxygenation. BiPAP provides an expiratory positive airway pressure and an inspiratory positive airway pressure to help ventilation. The indications for non-invasive ventilation include hypercapnic respiratory failure, chronic obstructive pulmonary disease, post-extubation and ventilator weaning, chest wall deformities, neuromuscular and obesity hypoventilation. Hypoxic respiratory failure indications include cardiogenic pulmonary edema, pneumonia, post-chest wall trauma without flail segment, and acute respiratory distress syndrome. Acute on chronic respiratory failure can also be an indication, and also for patients who are not for intubation. It is essential when starting non-invasive ventilation to speak to the patient, patient's family, and nominal physician regarding ceiling of care. Also, non-invasive ventilation should not be used as a substitute to tracheal intubation, and if the patient has impaired consciousness, severe hypoxemia or copious respiratory secretions, early intubation should be sought. Ideal prerequisites include a cooperative patient with preserved airway reflexes such as cough and gag, a patient who is able to coordinate with the ventilator and also breathe unaided for a few minutes at a time during breaks. Absolute contraindications include facial burns and trauma or recent facial or upper airway surgery, fixed obstruction of the upper airway, and vomiting. Relative contraindications are included if NIV is the ceiling of treatment, upper GI surgery, impaired consciousness or confusion, respiratory secretions, severe hypoxia, hemodynamic instability, bowel obstruction, or undrained pneumothorax. Ventilators required for NIV range from ICU ventilators normally employed for intubated patients to portable freestanding devices which are either pressure or volume controlled. Portable devices are at risk of rebreathing due to single tubing. Ideal ventilator features include pressure controlled, capable of 30 centimetres of water, with inspiratory flows of 60 litres a minute, assist control and bilevel support modes, a respiratory rate capable of 40 breaths per minute, and sensitive flow triggers and disconnection alarms. Triggering is critical to the outcome of NIV, and it is a complex field involving sensing inspiratory effort as well as determining the end of inspiration. Humidification may be required if prolonged periods of NIV or thick secretions, and the interface between the patient and the ventilator must be comfortable. Response to treatment will guide subsequent management and is done through clinical assessment regularly. Oxygen saturations must be monitored continuously and an arterial blood gas taken 1 to 2 hours after commencing NIV. NIV should continue during the first 24 hours for as much as possible. If a patient is failing NIV, early referral to ICU for consideration of endotracheal intubation is appropriate. Treatment of the underlying cause may be suboptimal and must review whether the patient is on the correct antibiotics or has an adequate diuresis, and any complications must be looked for, such as a pneumothorax or an aspiration pneumonia. If the PCO2 remains elevated, run through the following questions. Is the patient on too much oxygen? Is there excessive leakage? Is rebreathing occurring? Is the patient synchronizing with the ventilator? Is ventilation adequate? In summary, non-invasive ventilation requires a multidisciplinary approach to provide an optimum service in a level 2 environment. It requires doctors and nurses to have excellent clinical, practical and communication skills, and early decisions regarding ceiling of care and ICU input are essential.